I want to welcome everybody. My name is Christina Borbet, and I'm from the Now is the Time Technical Assistance Center. I'm joined by two experts in the field, and I'm so glad to have both of them contributing today. We're going to hear from Joe Markowitz, and we're also going to hear from Reggie Burke. I can tell there's a lot of interest in this topic because it's something that is impacting our students and our schools, and it's something that we're talking more and more about. And so I'm very glad to welcome both of these folks who could give us some concrete recommendations around prevention strategies and ways to address the opioid epidemic in the context of schools and our school communities. With that, I want to go ahead and introduce Joe. Joe, I'm going to check in about a couple of things. So we are able to share this information with both our Project Aware and our Healthy Transitions grantees under the Now is the Time initiative. And I also just wanted to mention that as we're moving into the content, that based on time, our presenters may choose to move through some of the content as part of the discussion, and then other resources and content can be available to you after the presentation. And so I will leave that to the discretion of both Joe and Reggie because we do want to make sure we have time for Q&A at the end of this session. Joe, I'll let you go ahead and move it forward from there.
Great, thanks, Christina. I'll reintroduce myself. I'm Joe Markowitz with Building Stronger Communities, and I have about 25 plus years of coalition experience and about 20 years of working with youth in large urban areas and rural areas and just working on prevention in general. So what we want to do today is kind of tie together some loose ends on opioid prevention and what's going on in a lot of our schools. So here's our agenda for the day. We're going to just quickly discuss the addictive nature of legal pharmaceutical opioids and the risks that are involved with young people. We want to look at a little bit of national youth survey data, clear up some myths about what's going on with our young people. We want to quickly discuss the connection between co-occurring disorders and students. And you're going to find by the end of this webinar that that's a big piece of the prevention piece of what we're trying to talk about today. We also want to highlight substance abuse and opioid prevention programs that involve schools, because a lot of you are out there as grant recipients working boots on the ground in the schools and the school communities. And the last piece of the agenda is just to highlight the efforts, what we're trying to do to address the opioid crisis in Maryland, and we have Reggie with us who's going to talk about that. So some of your learning objectives for today are going to be to understand the risk factors for the misuse of legal pharmaceutical opioids in young people. And I think for some of you, it's not going to be hard to understand these risk factors, and for others, it might be something that's eye-opening to you. The second objective is to understand the connection between co-occurring disorders and prescription misuse with youth. So if you're looking at prevention programming in your schools, you really want to highlight those high-risk students, and this is going to help with a little bit of that today. We also want to explore programs that address opioid misuse in the school community. So some of the programs that we present to you in the webinar today, you have heard of, and some of them you may not have heard of. So, and that's the whole idea of doing networking through webinar, is to highlight some of these programs. We're going to review resources available for parents and caregivers. And folks, there's more caregivers out there today than there are parents, and we have to educate them just as much, especially like grandparents. The last piece of your learning objectives is look what other states are doing about addressing the opioid crisis. And the two states we're probably going to refer to today are going to be Kentucky and Maryland. So this should be a great webinar. I think you're going to enjoy it. And as I said, I'm Joe Markowitz. I'm the Senior Consultant for Building Stronger Communities, and I'm just delighted to be here with you today. So let's just jump right into the national data. We know that heroin-related overdose deaths have more than quadrupled since 2010. And we know, especially from 2014 to 2015, that heroin overdose death rates increased by 20.6%, with over 13,000 people dying in 2015. So it's kind of going the wrong direction. We're not really impacting it yet. And overall, I don't know if you knew this or not, but the United States has 4.6% of the world population, but 80% of the opioid supply and 2/3 of the world's illegal drugs. So if you look at what's going on around our communities, you have to think about where are a lot of the illicit drugs, and why does the United States have so much of it? Okay, so that's something for us to think about. So here's a chart from the National Institute on Drug Abuse, and if you just generally look at it from 2002 to 2015, you can see that overall the number of overdose deaths from opioid drugs has gone up, and then you can also see the male and female trend lines as well. And I don't think this is any surprise to anyone, but I think when we're talking about the opioid crisis, we just have to make sure that we're looking at the data as well. So this is how we classify drugs in the United States, and there's 5 scheduled drugs, and the first one are the illicit drugs, heroin and fentanyl and things like that, things that are illegal. And really, what I'm really concerned about today in our conversation is those legal pharmaceutical opioids that are addictive in nature, that are common prescriptions among not only the adult community but the youth community as well. So that's kind of like what we're focusing on today is these legal pharmaceutical opioids. And we are actually going to skip the video for today, so we'll have more time for questions and answers, and I'm sure you guys will appreciate that. Let's talk for a second about the elevated risk factors for heroin use. And we look at the Center for Diseases Control, their vital signs report. You'll see that young people who suffer like a serious sports injury or even go in for a routine dental procedure, they can receive a prescription for a pharmaceutical opioid for pain that is at high risk for opioid addiction. And when we look at our efforts in our schools, in our communities, in our prevention coalitions, we know we're trying to get the word out about looking at who's prescribing for our children. And a lot of people are just unaware that these dangers exist. So that's really important. And the other high risk for legal opioid addiction is misusing a legal one that's prescribed to you. So if you look at, I think the numbers were 6 out of 10 individuals who are presently involved in heroin addiction have had a legal pharmaceutical opioid previously. So if we're looking at prevention and we're looking at, well, what can we do about this? We want to look at who is the audience that's highest at risk for this. And we're trying to keep young people in mind as we go through this. But those are your 2 highest elevated risk factors. Across the nation, you can look at a lot of different data sources. And if we just talk about heroin rates for young people, teenagers, we know that in 2015, that a little over 2% of students used heroin at least once in their life. So 2% of the teen population, according to the best resources we have at least tried heroin at least once. When you jump into like the National Youth Risk Behavior Survey and other surveys, you'll see that across 32 states across the country, heroin rates ranged from 0.09% to 5.9%. But when you got into the large urban districts, those rates went up. They ranged from 1.5% to 8.3%. So if you're looking at who's our target audience and who should we be getting the word out to, these numbers might drive a little bit of that for you. In my research for the webinar today, I was kind of interested to find out that in 2014, that according to the U.S. Department of Health and Human Services, 467,000 teens between 12 and 17 years old reported using prescription pain medications, and 168,000 of them admitting to being addicted to those painkillers, those pain medications. So the writing is kind of on the wall with young people and how they can get involved in this mess. So when we look at, well, what else can we do besides pain medication? One of the strategies we might want to seriously think about is alternative pain management. And we need to look at alternatives there. There are some doctors, and I've heard a lot of research, there are some doctors out there that believe that young people shouldn't receive any kind of an opioid for pain management, especially like if you're going to a dentist or you have a sports injury or something like that. There's a lot of doctors who believe that youth should not get those opioids. So that's just something for you to think about as you're moving ahead. And there are some clinical trials that indicate less addictive drugs can be just as effective as opioids. Don Teeter out of West Virginia did a lot of clinical studies, and he found out that when he had 2 control groups, one was given the pharmaceutical opioid and the other one was given ibuprofen and Tylenol, and they had the same outcome. So that was an interesting study, and I'm not throwing it out there that that's what we need to do for everyone, but that's worth more discussion and research to find out, is that true, those kinds of approaches. But we should be trying to think about things like that. Now let's take the idea of how do we impact this opioid epidemic from a community stance for a second. And what you see in front of you here is a common flow chart of what a community coalition prevention board looks like. Usually you have the community prevention board and you have a community mobilizer or convener or whatever you would call that person. And what we like to see from all the practices that I've been involved in is there's 6 primary focus areas that we can go after opioid prevention. Okay, and they go from reducing access to drugs to reducing inappropriate prescription use to improving drug overdose intervention with naloxone and Narcan and so on. Early treatment, identification, and recovery and reentry back into the community is a focus area. And getting mental health services more involved in folks who need it is the 5th focus area. But the 6th focus area, which is the one that I want to talk about, is our substance abuse prevention focus area. And this is our students in schools, and this is our primary prevention and our programs that are trying to help them. This is what we're kind of talking about today, is this 6th focus area. So we're going to take a few seconds to talk about efforts in the school environment. So we know, based on a lot of work that Hawkins and Catalano did with communities that care and so on and so forth, that the age of early onset of alcohol, tobacco, and drug use is a risk factor that increases the likelihood of future harder drug use. And we know that drug onset, alcohol, tobacco, and other drug onset actually hits young people, generally speaking, those who use it regularly, about 12 years of age or about 6th grade. So if you're looking at your prevention efforts, you want to be thinking that, hey, you know, students are getting active with alcohol, tobacco, and other drugs at the 6th grade level. So that's interesting to know. And the other piece of this, of these key points, is that mental health disorders co-occur with substance use. So we should be addressing both to be effective. So we need early identification and treatment. You know, there's a question out there, which one caused which one, like the chicken before the egg. But what we know through most of our studies is that these things co-occur together, and that's how they should be impacted. So there's a lot of evidence-informed, evidence-based programs. NREPP, our National Registry of Evidence-Based Prevention Programs, has a lot of programming there and a lot of assistance. Trauma-focused cognitive therapy, screening, brief intervention, referral to treatment. And I know a lot of you guys have seen these programs. Mental health first aid is out there. Now they have a youth version of mental health first aid, which is really cool. Teen screen for early detection and referral. And I want you to also think about those environmental impact strategies like the BAR program, which is building assets, reducing risks. We know based on science that when students go from 8th grade to 9th grade, they lose a lot of the prevention efforts that were given to them by programs in the schools in middle school. So we need to have something for them for that transition into high school. Because once they hit the front door in 9th grade, sometimes it's all bets are off on what they've learned. So the BAR program is an excellent example of an environmental strategy for a whole grade level. Now, this is something I want to share with you is if we had to pick priority areas of concern that impact youth and positive youth outcomes, from what I have seen from working with over 50,000 high school youth in my 20 years, is that a lot of them are talking about depression and anxiety, and we see the numbers that support that. Students talk to me a lot about self-medication with alcohol, tobacco, and other drugs, and the fact that they can go outside their door and within 30 minutes pretty much get whatever they want. It's illegal. So that availability of alcohol, tobacco, and drugs is an issue. For some communities and some youth, the fact that they don't see legal opioid use or illegal opioid use as a risk factor. They don't think it's dangerous. So that's an opportunity for a public awareness campaign. And the last two real quick, if we're talking about community-wide efforts, is laws and norms favorable to the problem behavior and favorable parental attitudes toward the problem behavior. Our young people are taught what is right and what is wrong many times in school, and they go back into an environment in their community that has a different message, and our young people are getting confused by those things. For example, we're not supposed to smoke marijuana, for example, in those states where it's illegal, but they'll go home and there's a family member smoking it regularly. This is perplexing to young people. So these are some areas of concern that in my 20 years of working with young people, these come up regularly, and we have to figure out how we're going to address these. There's been a lot of talk out there about naloxone in schools, and it's an interesting topic, and there are communities that support it, and there are communities that really don't want to support it. And I don't really say either way whether we should use it or not, but it's another tool in your tool chest if you think it's necessary. Some state lawmakers have authorized schools to have naloxone on hand, and the National Association of School Nurses endorsed this practice. So it's another tool in our toolkit However, just like anything else we worry about in our community is how accepting is our community of this. It's just something you need to think about if you want to move forward with an initiative like that. This is a program, and I'm trying to share with you some examples of some programs that are kind of innovative and out there. And there's a program that I've been involved in called Hiding in Plain Sight, and it's a great example of schools and communities and parents all coming together to work on this opioid awareness issue. And what they do is they set up a mock bedroom, and most of this is done in school auditoriums or school lunchrooms or gymnasiums, and law enforcement is usually involved in this as well. And what they do is they set up the bedroom and they put things in the mock bedroom that are signs to look for addictive substance use disorders. And what's really good about this is you'll get a parent or a caregiver or a grandparent come into a program like this and say, I had no idea. I didn't know where all the teaspoons were going out of our kitchen cabinet drawer. And then they find, 7 of the spoons in the bedroom because they were using it to, to get high on their drug. And they had no idea this was going on. So this is a great example of how schools and communities and prevention coalitions can all work together in a program. And also when they go through the mock bedroom setup, there's also plenty of educational materials and plenty of people and resources on hand to answer questions. So this is a really cool example of how we can work together. In Kentucky, and I want to share just something that we have done there. In 2017, the Kentucky State Attorney General started a program to hit. What we were doing was looking for the high burden counties, high rates of drug overdose death and high numbers of drug overdose deaths. And what can we do to get rid of unused prescription opioids? So if you have these things from people who are in the end of life situations, hospice and so on, and they have really serious addictive painkillers in their cabinet. What's happening with those? What are we doing with those? And what do we do with them? In the old days, we'd flush those things down the toilet. You can't do that anymore. So these drug deactivation pouches are a good example of how you would drop the prescription opioid into the packet, zip it shut, mix it up a little bit, and it deactivates the effective ingredient that still causes the high. So this was spread out for about 7 high burden counties. 50,000 of these pouches went out. This is a good example of a statewide approach to what do we do with our legal opioids. We're trying to get for safe disposal. And this is a good example of that. A lot of people have heard about lock boxes campaigns. One of the issues we have is youth who go over their friend's house and they go into their bathrooms and they see things in a medicine cabinet that they're trying to get their hands on to get high. And this is stuff we have to be really careful of. So there's a really good approach to doing a public awareness campaign to, again, parents and caregivers, those who might not think, I have OxyContin in my bathroom. No one's going to try to get high on that. And it's quite the opposite. So, where do we store those legal opioids? So that's something for you to think about. That's a really good initiative. And so those are a few examples of what we can do program-wise. I want to share with you now just a few thoughts about using youth data for planning. And when I do community assessments across the country with community coalitions, a lot of times youth data is left out of the assessment, and I always question that. I said, you got 5,000 students in our county who took this survey, and we're not sharing that information at our coalition needs assessment. So let me just show you a couple bits of those information. Like when we talk about the Youth Risk Behavior Surveillance Survey, the YRBS, when they did their national survey in 2015, over 15,000 students told people in that survey, 30% of them, 1/3 of the students felt sad or depressed most days of the week. 17% of those students considered suicide, and 14% of that 15,000 students had a suicide plan. Now, these are students who have to go to school every day. They're trying to graduate. They're trying to get through life. And my question is, what do we have for them in our schools, in our community, to help them through this? But I wanted to share those numbers because I find that alarming, and I find that when I share youth survey data with schools and prevention coalitions, this is often left out, and we just want to make sure we're utilizing this data. Part of the problem of those students who are having these issues is just coming to someone for help. And a couple ideas here of trying to remove the barriers for asking for help is having do our schools have a caring school climate? Are they able to approach their teacher? Can they go to someone for help? Can we train our teachers to identify high-risk students? Can we put anonymous drop-off boxes out in the school community so you're not afraid to ask for help? And of course, education awareness and public service announcements through the school that if you're having a problem, go to someone for help, and here's where you go. We talk a lot about co-occurring mental health issues and substance use disorders together. And this is like the 1-2 punch with being high risk for future opioid use. So we see some evidence connecting chronic depression and substance use to cope with emotional distress. And it puts students at high risk to dive into the opioid experimentation process just by nature of the things that they're trying to juggle in their life. So we want to be aware of that. And what are we doing for early detection and referral on that? A good example of working with students that are going through this is Systems of Care. It's an NREPP program that's sponsored or endorsed by SAMHSA. It's a community-driven process. What's really cool about it is many of these programs and initiatives are located at the school level, and there's a heavy emphasis on not only the youth being involved in the process, but the parents as well. Systems of Care is probably the best example I have seen of involving youth and parents in the process, and that's going to be effective in the long term. Talk about our community prevention coalitions for a second here, because we're doing all these things in the school, early identification programs, and that kind of thing. But how do we connect our students to it? And we want to see students as part of the solution, not part of the problem. So a lot of people say, well, we can't get students to our coalition meetings. Well, I would suggest you take your coalition meetings to the students. And I know many high schools who have had students conduct the meetings right in their school, and the coalition meetings members actually go to the school. So that's one suggestion for you. Talk to you real quick about student engagement in this whole prevention process. We should share youth data with them, and they should brainstorm activities. I've done 20 plus years of work coming up with action plans for students, stuff like this. Here's our priorities. We've looked at our youth survey data on the top, and here's our 5 priorities, depression or whatever. And down below is one event or activity we want to pull off in our school to address that issue. And this is just a sample action plan for our webinar today, but you can actually do this for the next 2 years of planning for your school. Probably the last piece I'm going to talk to you about real quick is just social norming and positive social norms. And this is actually not a new idea. It's been used in a lot of studies about bullying and relationships and onset of sexual activity and other things. And it's talking about what's acceptable in our community. And like I said, there's a lot of social science to support it. Basic idea here is this. On the left-hand side, misperceptions regarding negative behaviors in young people intensify the negative behavior. However, on the right, sharing the factual information about the majority of positive behavior has a positive effect. This is positive social norming. And this is a positive messaging campaign. And there's a lot of things that you can do with this in your community, your school community specifically. Not only can you promote the good news about young people and that most people are doing the right thing, you can also get your information out there about getting help and getting treatment for the problems that you're having. An example of positive social norming would be, instead of saying that 24% of students are involved in some kind of negative behavior, we could say 76% of students are alcohol-free, as opposed to looking at the negative. And it's the whole idea of social norming. Students love this stuff. Billboards, youth, our community's most valuable natural resource: student, athlete, mentor, employee, artist, leader. We really need to change the misperceptions about young people here. And I know I've gone through a lot of stuff rather quickly, but here's really what I want you to take away from this webinar from my aspect today. That number one, national data for young people looks encouraging. A lot of drug and alcohol rates have been going down in several states across the country. Now, recreational marijuana use does not happen to be one of them, and because of perceptions in the community, that could be causing that. The other thing is that legal opioids are dangerous, addictive, and considered a risk factor for future heroin use. And I've heard so many testimonies from parents who have lost children who were star athletes and good students and got good grades, and because they had a sports injury, they could not get off their pain medication. We need to get that message out there in our school community and to our parents and caregivers that this is something for us to seriously look at. We trust our doctors. We go to them for the right reason. We need to work together on getting the information out there. So that's going to be real critical. And the last few takeaways I have for you is that let's look at alternative forms of pain management. Let's look a little further into what are some other treatment options besides pharmaceutical opioids. And I'm not giving a bad rap because there's a place for opioid medication, but we need to question how often it's being prescribed. Number two, schools need to focus on co-occurring mental health and substance use disorders for effective intervention. That's really important. So how do our students get treatment? How do they get the information about treatment? How do we create a positive school climate so they're not afraid to ask for help for treatment? What do we have in place? It's time to take a serious look at, what's going on in our schools with that. Schools can promote wellness and reduce the barrier of students not asking for help. If you ask the students how to do this, they'll tell you how to do this. We sometimes come into schools with a plan. Let's get the students involved in that. Let's ask them how they would do it. And I think you'd be surprised with some of their answers. And the last thing I want to say is that this whole idea of positive social norming activities can help disprove perceptions about students and substance use. If students think that most youth aren't doing bad things, they'll buy into that. It's social marketing, and there's a lot of science to support that. Now, I don't think you should be out there saying everyone can run for president of the United States, but what I am saying is you can make it through school. You don't have to be involved in drugs and alcohol. You don't have to be involved in negative behaviors. And students will tell you that they firmly believe that. So I'm going to hold off on my questions because I'm going to turn it over to Reggie, who's here with us. And I know I went through a lot of stuff quickly, but I'll be more than willing to answer questions for you at the end of this session. So Reggie, are you there, buddy?
And Joe, I wanted to just encourage folks, if you do have questions that you'd like to start populating in the Q&A box, that will give Joe a chance to review them so that when we shift into the Q&A session at the end of this, he'll have kind of some prompts to start with. So go ahead and enter your questions into the Q&A box that you'd like us to consider for the Q&A session. And we'll go ahead and move from this high-level overview, and thank you so much for that, Joe, for the high-level overview and these kind of broad-level considerations to a deeper dive into a very specific context. We're welcoming Reggie Burke, who I'm so happy to have with us today from the state of Maryland, and Maryland is one of our AWARE grantees. Reggie has previously served as the Project AWARE project director for the last 3 years, and he has also had a key role in the state's task force addressing the opioid epidemic in Maryland. So Reggie, welcome, and I was hoping that you could walk our participants through some of the specific things that are happening in Maryland around the opioid epidemic.
Sure, Christina. Thank you, and I'm glad everybody is participating today. One of the things I wanted to, first of all, highlight, as Christina stated, I was the former program director for our Maryland Aware project. Currently, I serve as the director of the Youth Development Branch here at the Maryland State Department of Education. But more in sync, I guess, to this particular presentation, I serve as the Maryland Education Liaison to the Governor's Opioid Operational Command Center. And I'll talk in a couple of minutes more about what the Opioid Operational Command Center is in the kind of work that we do. The slide that I have up here now really just highlights the overdose fatalities that we've been having in Maryland. And you can see this is our 2016 report. You can look at the number of fatalities, how it really has spiked from 2007 to 2016. As you can see, in 2007, we had a little over 800 fatalities in Maryland due to overdoses, but in 2016, we were over 2,000. And even if you look at the jump between 2015 at 1,259 to 2016 at that 2,089, you can see we've really had a big spike in overdose fatalities. I would love to say that in 2017 our data is looking much better, but unfortunately it isn't. We are actually on a pace now. We've looked at the first two, I've seen the first 2 quarters of the data for Maryland, and it looks like we are going to easily surpass our 2016 fatality report in terms of the number of overdoses. So if you really look at the percentages, the number of opioid-related deaths increased by more than 70% just between 2015 and 2016, and it's really quadrupled in our state since 2010. We also have 89% of all intoxication deaths that occurred in Maryland in 2016 were opioid related. And really opioid related deaths, when we really talk about that, we're talking about deaths related to heroin, prescription opioids, and non-pharmaceutical fentanyl. What we have seen in the beginning of 2017, in the first 6 months, we have seen a decrease in the number of prescription fatalities, but we've seen an increase in the number of synthetic opioid fatalities. And the synthetic opioids that we are struggling with here in Maryland has been fentanyl over the last couple of years, and another synthetic opioid, which is carfentanil. And both of these synthetic opioids are much stronger than heroin and some of the other drugs that are out there. Between 2015 and 2016 in Maryland, the number of heroin-related deaths increased by 62%, from 748 to 1,212, and the number of fentanyl-related deaths tripled from 340 to 1,119. And in 2016, the number of prescription opioid-related deaths increased by 19% from 351 to 458, and many of those deaths occurred with the combination of heroin and fentanyl. And that's what we're really seeing across the state here, is a lot of deaths due to fentanyl and other synthetic opioids, but a lot of it is combined or mixed with heroin. The Opioid Operational Command Center was established by an executive order in January of 2017, so we're about a year in, and this was a part of our governor's heroin and opioid initiative. And basically the command center sounds like a physical location, but it's actually not. It really is a number of government agencies coming together, and we kind of serve as the coordination entity, and we really facilitate collaboration between federal, state, and local health and human services, education, public safety entities are at the table as well. So it's an excellent chance for a number of state agencies to come together. The four main agencies that are really at the table is education, public safety, which is our law enforcement, Department of Human Services, specifically social services, and Department of Health. And if you can think about it, those agencies don't generally come together often. And so one of the advantages, at least from the education side, that we have been able to pull from this command center is we have been able to give our schools and our school districts real-time information about what's going on in the streets in terms of the latest drugs, the spikes in particular areas throughout the state, protection guidance against synthetic opioids and things like that. And if you really think about it, normally schools don't get this information. Generally, that kind of information is reserved for law enforcement or health and medical. But with the creation of the Opioid Operational Command Center, we're able to share a lot of data with the schools and with the communities and with the families. And I think that has been extremely helpful. Now, we have been in, the governor has declared a state of emergency back in March of 2017. And it started out as a 60-day state of emergency, but it's really gone pretty much throughout the year. Technically, we are still in a state of emergency. We do know that we cannot stay in this state of emergency in Maryland forever. And so we're really trying to develop systems so that we have what we call a new normal in our state. And so we may not be in a state of emergency, but we're still putting a high priority and focus on the heroin epidemic. One of the advantages of the state of emergency, it really got rid of a lot of barriers. A lot of times when you have a lot of agencies coming together, there's difficulty with sharing information back and forth. And so the state of emergency did help that. So there was a little bit more information sharing between the state agencies that are at the table. And in Maryland, we have actually run our Opioid Operational Command Center very similar to the way we would operate if there was an emergency in the state, such as a hurricane or a or a blizzard or an earthquake or whatever the case may be. And that's because the command center is managed by MEMA, which is the Maryland Emergency Management Agency. It's Maryland's version of FEMA. And so we have an incident command center. We meet every week in what I call the situation room. It's where I guess many of the decisions are made when a state of emergency is in place in our state. And we actually are able to operate at that high level of function to address this epidemic. It is a little unusual, though, because if you think about it, most of the time when states are in a state of emergency, it's over a short period of time, and then they're going back to normal. However, the governor has felt this has been such a huge concern and problem in our state, he felt that the agency that needed to take the lead in this was the Maryland Emergency Management Agency. In terms of state initiatives, we have looked at a number of things at the state level and also at the local level and the schools. So one of the things we focused on, if we talk about the state level, it really goes back to the Opioid Command Center, where we've been able to collaborate and coordinate the state agencies together. Our governor has authorized over $50 million for the next 5 years to address this epidemic, and that's really about $10 million a year. A lot of the focus this first year of the 5 years, a lot of the dollars went to treatment and recovery. We had a small amount going to prevention. Obviously, we would like to have more of the dollars going to prevention, but the prevention dollars actually went to the local communities and basically the local opioid intervention teams. We have 24 counties in our state, and each one of those counties has a operating local intervention team that is made up of the local health managers, the local health department, the local school superintendent, and the local law enforcement agencies. And so the dollars have come to those agencies, and they've actually decided what's best for them, because we know what works in one part of the state may not work in the other. In terms of the schools, we've done a lot of surveys with our school systems, because one of the things we wanted to do was to find out what kind of promising practices or best practices are out there that we can kind of share and duplicate throughout the state. So in looking at the results of our surveys, most of our strategies, as you can imagine, has really been in the prevention tier. And a lot of that has been implementing evidence-based programs. Botfin Life Skills is a popular program that's been implemented throughout our state, which really focuses on building students' refusal and resistance skills. We still have a number of school systems using the DARE program with law enforcement. We've had a number of awareness activities with school assemblies and grade level assemblies. We've had a number of community awareness campaigns and parent meetings and those kind of things where we've given information to parents on how to make sure that their children are not abusing substances. We've had a number of high school students who are in drama departments put on student plays focusing on substance abuse, and they've taken those plays on the road, and they put those plays on in middle schools and elementary schools in their particular school districts. And we've had a lot of videos and documentaries of individuals in Maryland who have suffered or who are still suffering from drug addiction. We've also had a lot of staff training on naloxone administration. And we are one of the states that, and Joe mentioned earlier, where some states are requiring naloxone to be in all of the schools, and we are one of those. Through legislation last year, Maryland State Department of Education is required to collect data from schools anytime that Narcan or naloxone is being administered in a school building or in school grounds to a student or to an adult. And we've already had a couple of situations this school year where that has been the case. So all of our schools throughout Maryland are stocked with naloxone. We've had a lot of training. We've developed along with the Maryland Health Department, frequently asked questions and an administration guidance document to help our systems develop these kind of processes and programs. We also have tied in a lot of our schools with community-based organizations to provide support in treatment and recovery. But again, as I mentioned earlier, most of our work has really been in the prevention side. And just kind of wrap up, some of the resources needed along with the surveys, we really asked the school systems, what kind of supports, do you need to make sure that you are addressing this epidemic? One of the things, obviously, funding was number one, where schools felt they needed funding for staff training, guest speakers, community awareness events. They really wanted to look at expanding the health curriculum because in Maryland, many of our students don't touch a health teacher until they get to middle school. And so the last thing I want to talk about is that we have developed an online curriculum for many of our elementary school teachers who do not have a health background, but we want to make sure that our elementary school students are receiving substance abuse prevention as well. So those elementary schools where there is no health teacher, we are encouraging those staff to go through this online curriculum where they can teach some basic substance abuse prevention skills and strategies. And I'll wrap it up at that particular point. I know I have a couple of things on these slides here, a couple of websites. We have developed a opioid awareness and prevention toolkit, and the link is there. We also have updated our opioid prevention webpage, and one of the things we did with that was with our framework or our standards for the state, we have made sure that we have included the language of fentanyl and carfentanil. And the last thing I want to say is we start substance abuse prevention here in Maryland, beginning with curriculum in the 2nd grade. All right. That's all I have, and I guess at this point, if Christina or Joanna, we want to entertain questions at this particular point.
Yeah, thank you so much, Reggie. It's just been so helpful to hear what's happening in Maryland and how involved you've been through the State Department of Education in fielding strategies across the school population that are really meaningful. And I know that Joe's kind of broad scope overview of some of the concerns, the risk factors, and best practices in mitigating risks was also very helpful. And so what I want to do now is just ping our participants. I didn't see any questions entered into the Q&A box, but Joanne, I wonder if we could open the phone line so that if folks do have a question, they can go ahead and ask Joe or ask Reggie about some more specific details or examples they might be seeking to understand the resources that they've shared with us today.
Okay, so I've unmuted all of the users, so everyone should have the ability to ask any questions they'd like.
Great. Anybody want to start us off? I know that sometimes it can be hard to be the first one, so I'm going to volunteer a question that has come in from one of our Project Aware LEA communities. And Joe or Reggie, I think that you could probably both address this, so maybe Joe, we'll go ahead and start with you, and then Reggie, if you want to add any perspective, that would be helpful. One of the things that communities who are in states that do not have the statewide requirement for naloxone in schools, so for the states where that's optional, I understand that communities or school districts in particular feel like they don't want to be responsible for that and don't have enough information about what the administration of naloxone entails or what the liability considerations look like. And so they're reluctant to be one of the host sites for that. And I wondered if you could share a little bit with this audience about what the considerations there are for kind of building buy-in and helping schools understand what it means to be a site where naloxone is available.
Mm-hmm.
This is Joe. I'll just take a few seconds on this and then I'll let Reggie answer it. A couple considerations here is if you're going to have naloxone on site, does that mean at all sporting events that naloxone also has to be available? When a juvenile is in a medical situation and an adult is in their company, usually adults are responsible for that juvenile until emergency services gets there. So if you have a a situation where someone's watching a classroom or a school bus load of children, and they now have to put that on hold because they're not allowed to leave that student. That's just a liability thing you might want to think about. And Reggie, maybe you have better insight on that than I do, but it's just not a kit that is kept in a nurse's office. I mean, if you have on-school activities, you have to think about just the fact that there are youth on your premises, that they have to be eligible to receive that as well. Reggie, do you see that kind of stuff?
Sure, and you raised a good point. I think the biggest fear with many of our school systems in doing this is, Joe, what you just mentioned, is around the liability. And generally, folks have felt that way until they've actually gone through the training. And I think there really has been some misconceptions about, if I don't administer it correctly and if I'm, doing something wrong, what kind of liabilities are there. And of course, in Maryland, we have 24 local school districts. So they are actually developing their own policies, and they all look a little bit different. As I mentioned earlier, we have given them some guidance from our Department of Health along with the Maryland State Department of Education. And even before it was required, we had it in about 17 of our school districts for the last couple of years anyway. It's just been a requirement this year as a result of legislation, and specifically House Bill 1082, the Start Talking Maryland Act. And so I think once individuals have gone through the training and have seen how simple it is, the intranasal to administer naloxone, we actually have on our website, I know on the first page of our website was a video of a nurse in one of our school systems using a mannequin and administering the naloxone to really show how easy it is. And you're right, the liability is always a concern, but, saving lives and, things like that obviously is a huge concern. And one of the things we want to make sure, I believe, at the state is that we train, of course, as many people as possible, and that we have it on site and on staff. I mean, throughout our state, we have our police officers and first responders, utilizing naloxone, and they carry naloxone as, as part of their normal operating procedure. We have parents, using naloxone at home if they need it and stocking up. And so there is a liability issue, and of course that has to be addressed. But I do know that each one of our school systems, has a slightly different policy in how they are working out the liability. But that policy is also online on our Maryland State Department of Education website, and you can see the FAQ and the naloxone administration document. And I think I may have it also in the slides. I believe in my next to last slide, we have the link to it as well.
Yeah. Thank you, Reggie. That's really helpful, and it is great to have access to these concrete examples and templates in case local school districts or states want to look at what kinds of policies might work for them. Mm-hmm. So we do have time for another question. Go ahead.
Hi, I put my question in the chat box, but and I have to run to a meeting in 2 minutes, so I'm curious to know about any recommendations of tools that help to educate community coalitions about MTSS and PBIS, specifically around building the kind of infrastructure that can support community coalition work, opioid prevention and intervention work, and if both sides, because I know our schools are really invested in that, but I don't know if they always see the crossover between opioid prevention and things like MTSS or PBIS.
And this is Joe, and I've worked with hundreds of school districts, and it's really important that the school district be part of the local prevention coalition from stage one. They should be the planners, the conveners, and the implementers of the prevention programs, not brought in after the fact. They should be there from the get-go. So right from block one, they're helping plan these things. A lot of times you'll be doing these programs like PBIS and so on and so forth, and people don't make connections between those programs and, like, for example, your local coalition had anything to do with funding it and getting it into your school. So there's a breakdown in communication there. As far as tools, it's not just the school's job to get the information out there about how to do that. I think they need to lean on their prevention coalition, and this is that cooperative partnership that we need to have. And there are champions for every community coalition who can stand up and talk about the good things that are going on in your schools and support those programs.
Thanks, Joe. We are getting close to time, and I know that this is a really rich subject that we all care so much about because of the consequences that it has for our students and their families and our communities. We do want to, at the TA Center, offer to continue to field questions that you might have. If there's anything else that it would be useful for Joe or Reggie to address, you can go ahead and put it in the chat box or put it in the Q&A, and we'll make sure that Joe and Reggie have a chance to review it and respond. But I do want to thank both of our presenters today. Extraordinarily helpful lay of the land and some concrete tools and resources that we can take back to the work in our own communities. So much appreciated. I wish everybody a happy weekend. And again, thank you for your time on this really important topic today.
Thank you.
Thank you as well.
Thank you. Bye-bye.
Bye.